Dr. Sessler is the Michael Cudahy Professor and Chair of the Department of Outcomes Research at the Cleveland Clinic. He is also Director of the Outcomes Research Consortium. The consortium is the world's largest clinical anesthesia research group and publishes a full paper every 3 days. He is an editor for the journal Anesthesiology and serves as a reviewer for more than 50 journals. His grant totals now are in the range of $50 million US. This morning, we heard how important it was to try to develop publications that had high impact factors, and Dr. Sessler is the personification of that concept. He has published more than 700 full research papers, which have been cited more than 30,000 times. This makes him the world's most published anesthesiologist. His awards, among a list, include a Fulbright Fellowship and Excellence in Research Prize from the Anesthesiology Society. And with that, let's welcome Dr. Sessler.
It's my pleasure today to tell you about my favorite subject, which is thermoregulation. So I'm going to talk first about how anesthetics influence thermoregulation, then about heat balance, finally about the consequences of hypothermia, and then how to maintain normothermia. Body temperature is tightly regulated. And this is not just true in humans, by the way. It's true in all mammals, but it's also true in cold-blooded species. So if you give cold-blooded species a thermal gradient, they will all line up someplace very close to 37 degrees. And this is true for fungi and algae and bacteria and all sorts of things that you wouldn't think of. So there's something very fundamental about 37 degrees. The system consists of afferent input from the skin surface, from the core, which goes to the spinal cord, brain higher centers, the hypothalamus being the most important in humans, and then the hypothalamus activates thermoregulatory defenses. And it's these defenses that respond to the environment and keep core temperature near 37 degrees. Each of the major responses is controlled by a different threshold. The major responses in humans are sweating, vasoconstriction, and shivering. And of those, it's actually sweating and vasoconstriction that are the most important, and they are very close to each other. They're not identical, but the thresholds that activate sweating and vasoconstriction differ by only a couple of tenths of a degree. In fact, normal body temperature is defined by that range, because temperatures in that range do not trigger thermoregulatory defenses. Note that shivering has a threshold that's a full degree below the vasoconstriction threshold. So by the time patients start to shiver, they're really quite cold. They're about a degree hypothermic already. Normally, body temperature is in that range there. Now, things change markedly when you give people anesthetics. This figure shows the dose-dependent effects of various anesthetic drugs on thermoregulatory thresholds. They all have a similar format. On the x-axis is the range of concentrations over the clinically relevant range. And on the y-axis, you have the temperature that triggers various responses. And in each case, you have sweating, vasoconstriction, and shivering. And you see the results for desflurane, a volatile anesthetic, alfentanil, an opioid, dexmedetomidine, central alpha agonist, and propofol, an intravenous anesthetic. Now, what's interesting here is that all these figures are roughly similar. They're not identical, but they are similar. In each case, you start with no effect at 0 concentration. In fact, The entire previous slide I showed you was in that little red box there. That gives you an idea of how expanded the scale is. Or, put this another way, how much anesthetic drugs impair thermoregulatory control. In each case, the sweating threshold doesn't change very much. Anesthetic drugs do not much impair the response to heat. In contrast, the vasoconstriction and shivering thresholds decrease markedly. The rate at which it decreases, even the pattern, differs with different drugs, but in each case, there is a dose-dependent reduction in the vasoconstriction and shivering thresholds. And because the sweating threshold stays about the same, the difference between those, which is called the interthreshold range, increases markedly, typically 10 to 20-fold. So it is not true that anesthetized patients are poikilothermic. They will respond to hypothermia, but they don't respond until they're quite hypothermic, typically on the order of 34.5 degrees with your typical gamish of anesthetic drugs. And before patients were routinely warmed, they almost all showed up in the PACU, in the post-anesthesia care unit, at about 34.5 degrees. That was not a random temperature. It was because at 34.5 degrees, thermoregulatory responses kick in and they protected patients, prevented them from getting more hypothermic. The combination of anesthetic-induced thermoregulatory impairment and a cool operating room makes patients hypothermic. Hypothermia develops with a typical three-part characteristic curve. Initially, there is a very rapid decrease in core temperature lasting 40 to 60 minutes. This is followed by a slower, linear decrease in core temperature, typically lasting 2 to 3 hours. And in patients who get cold enough, you reach a core temperature plateau. Each phase of this curve has a different cause, so I'm going to go through them in turn. The initial rapid decrease in core temperature results from an internal core to peripheral redistribution of body heat. It is not, as you might intuitively expect, from heat loss to the environment. So yes, I appreciate this is the period when patients are completely exposed and they're in a cold operating room, but the cause of the initial hypothermia is a large flow of heat from the core thermal compartment out into the periphery. It is not actually heat loss from the periphery to the environment. The reason it happens is that core temperature is not average body temperature. Core temperature is the temperature of the trunk and the head, the highly perfused central organs. Arms and legs, which effectively are the peripheral compartment, are anywhere from 2 to 4 degrees cooler than the core. That gradient between the core and the periphery is maintained by tonic thermoregulatory vasoconstriction. But remember, I just showed you that all anesthetic drugs reduce the vasoconstriction threshold. So as soon as you give people anesthesia, they vasodilate, and that allows heat to leave the core and move out into the periphery. So, for example, sometimes it's hard to start an IV in patients because they have really no veins, you can't see anything, and then you induce anesthesia and all the veins pop up, and you think, oh, that's because anesthetics are vasodilating. But that's not actually the reason, because it happens even with vasoconstricting anesthetics. It's because the anesthetics impair central tonic thermoregulatory vasoconstriction. So anesthetics promote vasodilation, and that's what causes this initial core to peripheral redistribution. The second phase is the one that's obvious. This results from heat loss to the environment exceeding metabolic heat production. The two most important causes are radiation and convection. Conduction and evaporation in most patients does not contribute an important amount. And the third phase, the plateau, occurs only in patients who become very hypothermic. Note that this is 3 degrees of hypothermia here. That happens when patients get cold enough to again trigger vasoconstriction. Vasoconstriction, even during anesthesia, is effective. It constrains metabolic heat to the core and it prevents further hypothermia. So to summarize for general anesthesia, central thermoregulatory inhibition does not do much to warm responses, but it profoundly reduces the vasoconstriction and shivering thresholds. As a result, the interthreshold range increases and patients over a broad range of core temperature are poikilothermic. Intraoperative hypothermia results initially from this core to peripheral redistribution, subsequently from heat loss exceeding heat production, and finally, just in patients who become cold enough, you get reemergence of vasoconstriction, and that prevents further hypothermia. Interestingly, there are thermoregulatory problems with spinal anesthesia also, and there are 3 of them. The first is, quite surprisingly, there is a central impairment of thermoregulatory control during neuraxial anesthesia. So even though we give, say, 1 to 2 mLs of local anesthetic at the base of the spinal cord, central thermoregulation is impaired. Now, why this is true is unclear, but the pattern is similar to that during general anesthesia. So the sweating threshold goes up a little bit, vasoconstriction and shivering thresholds go down, and the result is that the interthreshold range increases. Now, the magnitude is much smaller than with general anesthesia, but it remains curious that, say, a spinal anesthetic would produce central impairment of thermoregulatory control. That was the first problem. The second problem is that all thermoregulatory responses are neurally mediated. They are not hormonally mediated, which means that if you have any sort of block, such as a spinal or an epidural, in the blocked region, there are no thermoregulatory defenses. Patients cannot vasoconstrict, they cannot shiver through a block. So, in patients who have neuraxial anesthesia, they have a central impairment, we already talked about that, so they start shivering at a lower temperature, and they are unable to shiver as much as without a block. Now, this is not actually very surprising. After all, if the legs are paralyzed, the legs have lots of big muscles, you wouldn't expect shivering on the whole body basis to be as effective, and it's not. But that's the second problem with neuraxial anesthesia. You have peripheral impairment of thermoregulatory defenses. The third problem is a behavioral one. So, this is a study where we took some volunteers, me among them, and we gave them epidural anesthesia. Well, epidural anesthesia causes hypothermia because of central impairment, redistribution hypothermia. It's exactly the same as with general anesthesia. So our volunteers got colder and colder. But at the same time, we were asking them, how comfortable do you feel? Tell us about your thermal comfort. And there the answers were surprising. After induction of epidural anesthesia, they felt warmer. Now, maybe that's not actually terribly surprising, because when you do a spinal or an epidural anesthetic, the first thing that happens is the patient looks up and says, my legs feel warm. Well, that feeling warm in the legs contributes to their overall sense of warmth. So they feel warmer. But look what happened here. The point of maximum thermal comfort was actually exactly when they had the minimum core temperature. So this is a behavioral problem. Patients who are getting hypothermic during neuraxial anesthesia don't recognize it. They feel, if anything, warmer than they did before the block. So if you're not measuring core temperature, and core temperature is often not measured during neuraxial anesthesia, you can't tell whether your patient's hypothermic by just asking them, do you feel warm? Because they will say, yes, I feel warm, no matter how hypothermic they are. So to summarize, for neuraxial anesthesia, you get central impairment of thermoregulatory control. You have peripheral impairment because all thermoregulatory defenses are neurally mediated and block nerves can't mediate them. You have this behavioral inhibition, so patients feel warm even when they're not. Consequently, patients who have neuraxial anesthesia get as hypothermic as patients having a general anesthetic. So for a given sized operation, they get just as hypothermic. There's nothing protective about neuraxial anesthesia. Well, does it matter? Yes, it does. The consequences of hypothermia have been well studied. So these are relatively large randomized trials, high quality evidence, and there are many consequences of hypothermia. Not every patient is susceptible to every complication, of course, but it's actually the rare patient who is not susceptible to at least one of the complications of hypothermia, because many different systems are affected. You can turn this around. I started by saying that core temperature is highly, highly defended in mammals and, in fact, in poikilothermic species. Why is that? It's because it matters. The best documented consequence of hypothermia is coagulopathy. So this has been studied many times. We did the original and largest studies, and this is our meta-analysis. The results are absolutely clear. A degree of hypothermia increases blood loss by about 20%. So during hip surgery, for example, where blood loss is very much an issue, if your patients are hypothermic, you will have more bleeding, and you will require more blood. So there's about a 20% increase in the risk of needing blood per degree of hypothermia. Hypothermia also promotes surgical site infection. So there are two large randomized trials that evaluated this. And there are several reasons why this would be true. One is that hypothermia promotes vasoconstriction, at least postoperatively, and that inhibits delivery of immune cells to the wounded tissues. It also decreases oxygen delivery to the wound. Hypothermia directly impairs motility of macrophages. And finally, hypothermia reduces scar formation. Now, I know you think you don't want a scar, but scars, or the scar healing process, is of course what knits wounds together and prevents reinfection. Hypothermia makes that process slower. So perhaps unsurprisingly, normothermic patients had a considerably lower risk of surgical site infection in this randomized trial, and the results were almost the same in the other randomized trial. The duration of hospitalization was also prolonged by about 20% in this study. Now, recently, there has been considerable concern about laminar flow and forced air warming and the effect on bacteria. And I'm afraid much of this has been directed at orthopedic surgeons. So I want to take a few minutes and talk about this issue. It is largely, well, let me start by saying that the available evidence for laminar flow is that it worsens infection risk. Okay? Now, everybody uses laminar flow, of course, to reduce infection risk, but a meta-analysis of available studies shows that laminar flow actually increases infection risk. That's a little counterintuitive, but it probably happens because these very large flows of air grab particles from people standing around the patient. These particles are contaminated, and the laminar flow drives them right into the wound. So you actually do better without laminar flow. The concerns about laminar flow and forced air only apply to laminar flow, but I appreciate that many of you work in operating rooms where laminar flow is there. So we need to talk about that. The theory is that forced air, because it's warm, pushes up against the laminar flow and disturbs its function. The theory is based on a bunch of laboratory simulations, which are done in various configurations, and they're all highly artificial. We did one of these, and the one we did shows no important effect whatsoever. So these are reductions in particle counts during laminar flow without forced air, with forced air on ambient temperature, and with forced air heated, as it normally is, to 43 degrees. And in each case, we see huge reductions from baseline, way below the official defined limit for the function of laminar flow systems. So basically, we don't see an important effect here. Other simulations do show an effect, but keep in mind, they're all simulations. They're all highly artificial circumstances. There is exactly one clinically relevant study. It was done by Aguz and colleagues. I was not involved in this study. They took 80 patients having orthopedic surgery, and half had laminar flow, and they were randomized to either bear hug or warming or to resistive heating. What the investigators did was they put culture plates all around patients, okay? So these were real patients having real surgery, and they simply put out culture plates all around to look for bacteria that landed on the culture plates. There was no effect whatsoever of forced air warming. The odds ratio for bacterial growth was 1.0, just absolutely no effect. And this study was large enough, it was well-powered. These are pretty good data. Basically, in the only clinical study of forced air and laminar flow, no effect whatsoever. The FDA has weighed in on this topic, and I'm just going to read this because I think it's so important. They conclude, therefore, the FDA continues to recommend the use of thermoregulating devices, including forced air thermoregulating systems. So basically, the FDA has given forced air a clean bill of health, even during laminar flow and for orthopedic surgery. There is no compelling evidence to avoid forced air. Let's go on now and talk about other complications. Enzymes are phenomenally sensitive to temperature, and so it is not surprising that hypothermic patients don't metabolize drugs normally. So this was the first study we did on the topic. We took volunteers, we anesthetized them once at normothermia, once 2 degrees hypothermic. Each time gave them a dose of the muscle relaxant vecuronium. When patients were the volunteers were hypothermic, the duration of action of vecuronium was doubled. In fact, the duration of action of vecuronium in these hypothermic patients exceeded the duration of pancuronium. So this was a substantial effect. We have since looked at a number of other drugs, and the effects are less extreme. We don't see a factor 2 with other drugs, but we see between 30 and 60% for drugs like propofol and other muscle relaxants. So hypothermia delays drug metabolism. The reason that's important is that if patients don't metabolize the drugs, they don't wake up. Or even if they wake up, they're sort of woozy, it takes them a long time to recover, they don't feel well. Anesthesiologists pay extra to get really short-acting drugs so that we can get people to sleep quickly and we can wake them up at the end. If patients get hypothermic, we've wasted that extra money because short-acting drugs act like long-acting drugs in patients who are hypothermic. Unsurprisingly, hypothermic patients recover more slowly, and presumably simply because the drugs hang around longer. So they take longer to recover. In this study, hypothermic patients took 40 minutes longer to be ready for discharge. That's a long time. Remember, patients typically stay in the post-anesthesia care unit for about an hour. Add 40 minutes to that. That's a substantial increase. Not good. It reflects the fact that the drugs are hanging around, the patients aren't waking up well. And then finally, hypothermia makes patients uncomfortable. Now, fortunately, we don't see 2 degrees of hypothermia, which is what this is based on, much anymore. But patients who are 2 degrees hypothermic feel very, very uncomfortably cold. They shiver, they feel miserable, and it takes them 2 full hours to return to being comfortable again. So even if hypothermia did none of the other things that I've told you about, even if it was just a matter of making patients feel uncomfortable, I'd still say we should keep patients warm. After all, we spend lots of money and effort, quite appropriately, treating pain. Well, pain is just a matter of comfort. Thermal discomfort is intense. And in fact, when you talk to patients years later, you ask them, have you ever had an operation? Oh yeah, I had surgery. What was the worst part? That feeling cold. Feeling cold and shivering, that was the worst thing. Worse than the pain? Yeah, doc, it was worse than the pain. Somehow people remember that feeling cold, whereas the memory of the pain goes away over time. So to summarize, the major complications are bleeding, increased transfusion requirement, and wound infection. But hypothermia also decreases drug metabolism, it prolongs recovery, and it makes patients really uncomfortable. Question then is, what can you do about it? Well, the easiest way to reduce heat loss in surgical patients is to cover them with some insulator. And there are lots and lots of insulators hanging around every operating room. So you have everything, plastic bags, cotton blankets, different types of surgical drapes, and then things like space blankets. Well, it turns out they all work. They all reduce heat loss by about 30%, which is a clinically important amount. But there is no important difference among the covers. So a plastic bag hardly works, or almost works, as well as a space blanket, which of course costs a lot more. That may sound counterintuitive, but the reason is that it's not the insulator that matters. It's that little bit of still air under the insulator. It's the air that's providing the insulation, not the material of the insulator. So If you're going to insulate people, cotton blanket, plastic bag, whatever you want, they all work equally well. The trouble is that while 30% is a clinically important reduction in heat loss, it's not enough. It is almost never enough to compensate for the big losses during surgery, which include evaporative losses from within incisions. And by the way, adding more layers of passive insulation doesn't help as much as you would think. So one layer gives you 30%, 3 layers only gives you 50% though. So if your patients are getting hypothermic with 1 layer of insulation, just adding another couple of layers won't work. You're going to need to go to some other system. And the one you will probably go to is forced air. And I'm not saying that because forced air is the only system, not necessarily even the best system. There are more expensive systems that transfer more heat. There are less expensive systems that transfer less heat. It's just that worldwide, forced air is by far the most common way of warming surgical patients. Something like 90% of all warmed patients worldwide are warmed with forced air. And there are good reasons to use forced air because it's effective, it's easy to use, it's inexpensive, and it's drop-dead safe. So I don't actually care how you warm patients. You can use any system you want, but forced air is a good choice. Let's talk now about pre-warming. Remember I said that the initial hypothermia after induction of anesthesia, during that initial 40 minutes or so, is from this internal redistribution of body heat. It is almost impossible to treat this. Even a very effective warmer used during the first hour of anesthesia does not prevent redistribution hypothermia. And the reason is that it comes from this large internal flow of heat. It is not, counterintuitive as it may seem, come from heat loss from the skin surface to the environment. It's all happening inside. Virtually impossible to treat. But you can prevent it, or at least a lot of it. And the way you prevent it is to pre-warm patients. What I mean by that is warming patients for 30 or 40 minutes before induction of anesthesia. 10 minutes won't do it. You need to do, say, 30 minutes. And it needs to be real warming. I'm not talking about just jacking up the ambient temperature a little bit. I mean 30 minutes of active warming. But if you do that, you will transfer a lot of heat into the peripheral thermal compartment. It will not change core temperature one bit. Remember, this is before anesthesia. Patients are still regulating core temperature perfectly well. So pre-warming does not change core temperature. That's still regulated. But the heat is going into the body, and it stays in the peripheral thermal compartment. If you pre-warm patients long enough, their peripheral tissue temperature comes up and almost equals core temperature. The second law of thermodynamics says that heat can only flow down a temperature gradient. If there is no important temperature gradient between the core and the periphery, there cannot be a flow of heat, and therefore there's no redistribution hypothermia. So that's the theory, but it turns out that it's true. It does work. So this is an example. So this is a full hour of pre-warming. Note that it did almost nothing to core temperature, tenths of a degree or something to core temperature. But after induction of anesthesia, here at time 0, the pre-warm patients hardly went down, staying well above 36 degrees an hour later with no warming after induction of anesthesia, whereas the ones who were cooled became quite hypothermic and were down at about 35 degrees an hour after anesthesia. So it does work. The trouble is that it doesn't work terribly well. So despite that example, a meta-analysis of clinical pre-warming trials, of which there have been many, shows that it absolutely clearly works. This is not a matter of statistical significance, The statistical significance is absolutely clear. It's a matter of magnitude. The magnitude is only about a half degree. So pre-warming does work, it's just not an enormous effect. So if you want to use pre-warming, fits into your system, great, use it. But I am not running around anymore saying you have to pre-warm all the patients because the effect is relatively small. Fluid warming is another thing we should talk about. It is not possible to warm patients by warming fluids because you can't warm the fluids to very much above body temperature. And so with the volumes you can give during surgery, the amount of heat you transfer is trivial. So fluid warming does not keep people warm. Fluid warming is never a primary warming method. On the other hand, if you give people lots of cold fluid, you absolutely can cool them down. The amount of cooling is 1/4 degree decrease in mean body temperature per liter of crystalloid at ambient temperature. A unit of blood also decreases mean body temperature by 1/4 degree. Well, it's half the volume and twice as cold. It has exactly the same cooling effect. So it does not make sense, for example, to give 5 liters of unwarmed fluid and then hook up a blood warmer to give 1 unit of blood. Each of those units has exactly the same cooling characteristics. So if you're giving, say, 1 liter an hour or 1 liter over a couple of hours, don't bother with fluid warming. We don't care about 1/4 degree effects. If you're giving lots of fluid, as you might during hip surgery, where there's much more blood loss, then fluid should be warmed. But it's a matter of volume. And let's talk about ambient temperature. This will make you happy, I promise. Okay, so ambient temperature certainly promotes temperature or heat loss from people because the amount of heat that's lost is a function of the gradient between exposed skin surface, the ambient air, and the temperature of the walls of the room. Radiant heating doesn't care about the air, it cares only about the temperature of the walls. But the temperature of the wall tends to be the same as the temperature of the air. So in cold environments, without forced air warming, patients become colder in colder rooms. But the effect turns out to be quite small. So this is a just published study, so 300 some patients, 2x3 factorial design trial. Let's start by looking at the patients who did not have forced air. These are the ones down here. So ambient temperature was 19, 21, or 23 degrees. There was a distinct difference. So patients in a colder environment who were not warmed with forced air did end up colder at the end of surgery. But the differences were really small. The entire difference between 19 and 23 degrees was only little more than half a degree. It's just not a big deal. So even in unwarmed patients, ambient temperature is not something to really worry about. So there's discussion before about thermal comfort for the surgeons, which I take seriously, by the way. I fully appreciate you're working hard, you're doing a job. Thermal comfort degrades performance. You deserve to be comfortable, and you should be comfortable because it will enhance your performance. No problem. Ambient temperature is low. It will not have very much effect on your patient's temperature, even if they're not actively warmed with forced air. But here's the good part. If they're warmed with forced air, it makes no difference whatsoever. None. And the reason, of course, is that what the patient sees is the forced air cocoon around them. Even if the cover isn't covering the whole body, the air still percolates around under the surgical drapes. What the patient sees is the temperature of the forced air, not the room. And therefore, room temperature doesn't matter. You can set the room temperature anywhere you want, especially if you're actively warming patients with forced air. So that brings me to my rule, which is, first, you need to monitor core temperature. You don't monitor it, you won't know what it is. Core temperature is not something where you can reach over, feel the patient. You can't look. You can't ask a patient having neuraxial anesthesia because they'll give you exactly the wrong answer. If you're not actually measuring core temperature, you simply won't know about it. So rule one, monitor core temperature. For the big operations you do, you can anticipate hypothermia. If you don't measure core temperature, you won't know where you are. And the second is, based on many large randomized trials, very high-level evidence, you should keep your patients normothermic. You should keep your patients at least 36 degrees by the end of surgery, and preferably not dipping too much during surgery. I do not care how you keep your patients normothermic. There are lots of ways of maintaining normothermia. I don't care at all which one you choose. But I do care a lot that surgical patients are kept normothermic because even mild hypothermia causes many complications. Thank you much. And I would be delighted to take questions.
Terrific presentation. Do you have any information or thoughts on, say, if we operate on a hip replacement case that's infected and we're using 9 or 10 liters of fluid to irrigate the wound, is that an issue or is that a non-issue?
Okay, the question is whether wound irrigation causes hypothermia. Probably not very much. It has not been studied, but the fluid that you're using is not absorbed. It's basically bouncing off the tissues, and probably not very much of that cold actually gets absorbed by patients. But as I said, it's not been studied, but I'm guessing this is not an enormous effect. I certainly wouldn't hesitate to use as much irrigation as you think is clinically appropriate.
That was a great presentation. Thank you very much. In some hospitals where I work, there's no option for forced air. So what would you recommend to help us control, besides a blanket, what else can we do to help control temperature?
Okay. The observation was that in some hospitals, there is no option to use forced air or any other active warming system. I would say that is not really within the Western standard of care. Hospitals really should provide some sort of active warming system. I think you need to have a discussion with the hospital folks. That just is not within the standard of care anymore. Okay. Question is, in a hospital that for some reason or another doesn't have active surface warming, is fluid warming sufficient? Absolutely not. So I'm not saying don't warm fluids. You should warm fluids. But warming fluids will not compensate for heat loss from the skin surface, much less from within surgical incisions, nor for redistribution hypothermia. Only an active cutaneous warming system will work. And fluid warming is just not a substitute. Fluid warming is always a second line. You start with some surface warming, and then if you're giving large amounts of fluid, add fluid warming.
Dr. Sessler, fantastic talk as always. The warming the patient and normothermia, which we all know has been endorsed by many organizations, including the CDC. You did say in your sentence, unless I misunderstood you, that a meta-analysis has been done that shows laminar flow room increases the risk of infection. Can you clarify, are these really truly meta-analyses? And if so, where are they published?
I can get you the reference for it. It was published. It's a true meta-analysis of a limited number of studies, and the studies were observational. So these are not big trials. There has never been a large trial of laminar flow. So all we have are observational data. It's not as good as randomized data, but it's not worthless either. Good quality observational studies can be valuable. It's what we have at the moment.
You know, just for the sake of all of us in this room, before we walk out and condemn laminar flow, and I have no feelings one way or the other, and I completely agree with you that I don't think laminar flow is protective against infection, but to conclude otherwise or against it is also probably not justified. We know that WHO has said that laminar flow room increases the risk of infection, and if you look at their document, they only cite one study from New Zealand registry, which in my opinion, and with all due respect to my great New Zealand colleagues, was flawed. Because the same study also shows antibiotic impregnated cement increases the risk of infection. The only great study that's been done on this that's relevant to us in orthopedic surgery is the Lidwell study from the 1980s, randomized prospective. Dr. John Lee himself believed very much in the concept of clean room air. And your point about contaminated forced down, we don't have proper filters. But the way laminar is supposed to work is compartments that will isolate particles away from the incision. That's the theoretical aspect of how laminar flow is supposed to work. Now, whether that happens or not, whether people maintain their filters or not, all of these are questions. But I just was a little worried for us to walk out of here to conclude that laminar flow room increases the risk of infection based on meta-analysis. It's probably a systematic review because it cannot be meta-analysis because there's only one randomized prospective study, I'm aware of it. And just for instance, no definitive link between the use of laminar flow room and increased infection. One thing we do know, beautifully articulated, is that the number of airborne particles in the operating room are important, and the higher those number of particles are, the higher the likelihood of infection. Is that a fair statement, or am I sort of trying to force you to say something you don't want to say?
I'm not sure I can repeat that question, but I'll talk. The comment is that the evidence for laminar flow being harmful or beneficial is really weak, and maybe the most accurate statement is that there is no compelling evidence that laminar flow is helpful, and whether it's harmful or not may be unclear, but there's a paucity of evidence for benefit, for sure. Now, there was some talk earlier about ambient temperature and bacteria feeling comfortable. The number of bacteria in the room do matter because the number of bacteria in the room influence how many get into an incision. But keep in mind, sterility in operating rooms is only relative. The moment you make an incision, that wound becomes contaminated. Every surgical wound is contaminated. Only a tiny fraction become infected. What determines whether contamination progresses to infection is host defense. It's not the ambient temperature and whether the bacteria are feeling comfortable. That has nothing to do with it. This is all a matter of host defense. That's why normothermia is so important, because even a little bit of hypothermia impairs host defense. That's the important determinant of whether you get an infection or not.
Thank you.
Hi, thank you for your great talk. I'm Koji from Japan. I have two questions. Is there any evidence or data that shows that the laminar airflow is correlated with the body temperature decrease. That's number one. And number two is the irrigation, the temperature of the irrigation. What do you think? You should keep it hot, and what threshold? Is there any that shows the effectiveness of the that maintains body temperature?
The first question was, what is the relationship between laminar flow and body temperature, which I think is a question of, does laminar flow suck a lot of heat out of patients? That's unknown at the moment. We actually tried to study it once, and we couldn't because our laminar flow system sort of turns the heater on and off randomly by large amounts, and so we technically could not do the study. And I'm sorry, I didn't understand your second question.
The second question was the temperature of the irrigation solution.
Yeah.
What we use to irrigate the wound. Is there any temperature that you recommend or any data which maintain the...
Is there a temperature I recommend for wound irrigation? The effect of wound irrigation on body temperature is unclear. Certainly, if you're dropping liters into the peritoneum, that heat is very quickly absorbed by patients. But when you're just sort of bouncing it off of an orthopedic incision, probably has less effect. If you can use something near body temperature, great, but I'm guessing it's a small effect. That in patients who are adequately warmed with a surface system, that irrigation probably doesn't cool them much. Yes.
I really enjoy your talk, Professor. The fever is another kind of a defense mechanism, right? So is there any benefit that increase the body temperature by hyperthermia that can boost patients' immunity or fight against the infection based on your study?
Okay, the question is basically, what about fever? And I think if you increase core temperature to febrile regions, would that help? Probably not. Fever is not just hyperthermia. Hyperthermia is defined as any elevation in core temperature, but that can come from excessive environmental exposure, let's say being in a chemical weapon suit in the desert, or it can come from excessive heat production, think heat stroke in athletes, or from malignant hyperthermia. But the major cause of hyperthermia is fever. This is a regulated increase in core temperature. So febrile patients define and defend their febrile temperatures just the way you right now are defending your normal temperature. But artificially increasing somebody to a febrile range doesn't do the same thing. It doesn't activate all the immune systems that are part of the febrile response.
Thank you for your excellent presentation. Just a quick question. Do you know if there is any difference between lateral decubitus and supine position of the patient, because the core temperature, you're supine, maybe your chest is more protected in the back, and then if you're lateral decubitus, you only have one surface against the bed. Does it make any sense or not?
Okay, the question is what about supine versus lateral position in terms of what, core temperature or heat loss? Okay, in terms of heat loss, probably it does not make an enormous difference what position patients are in, especially once they're draped, and certainly if you have forced air under your drape, that's what they're going to see. So maybe there's a small effect of position, but I'm guessing it's relatively small. It's never been formally studied.
Do you have any information regarding liquids for arthroscopic procedures? Because when you do arthroscopic, there's a lot of fluids going around patients. Should you warm those fluids up, or does not make any difference?
Okay. The question is, what about laparoscopic procedures where there's a lot of continuous irrigation? Arthroscopic procedures. Right. It probably doesn't make very much difference because heat absorption, say from a knee chamber, is going to be really small. So I think that's going to be a very small effect. We once studied bladder irrigation as a potential way of cooling people during a malignant hyperthermia crisis, and it doesn't work at all. Turns out the bladder is really well insulated. And the bladder, of course, is far more central than a knee joint. I imagine it makes no difference whatsoever. Okay.